Good morning, sir. Good morning, ma'am. I am Dr. Rajalaxmi from GMC Nanded. My guide is Dr. Amit sir and Dr. Kalyani ma'am. My topic is ultrasound diagnosis of ruptured scar of previous Caesarean section with complete expulsion of fetus into maternal abdomen in 2 patients. So intro, antepartum uterine rupture is one of the obstetric emergencies which requires emergency surgical management. Previous Caesarean section scar is a major predisposing factor for uterine rupture in antepartum period and during labor, and ultrasound plays a major role in diagnosis of uterine rupture. So there are many causes of uterine rupture. Starting from previous surgeries, one of the major reasons for scar rupture is previous surgeries, anything done to the uterus, Caesarean, myomectomy, metroplasty, uterine curettage, etc., or obstructed labor due to malposition, malpresentation, or induction or augmentation of labor using oxytocin or prostaglandins, and maneuvers like internal prodalic version or external cephalic version, and due to congenital anomalies like pregnancy in undeveloped uterine horn or in uterine didelphys. So here I present 2 cases. One is in third trimester, and the other one was second trimester scar rupture. So in third trimester scar rupture, a 24-year-old woman with 9 months of amenorrhea presented with PV bleeding with documented intrauterine pregnancy in previous ANC scan. She had previous history of 1 LSCS 18 months back. Patient was referred to rule out abruption or rupture. On examination, FHS was present, fetal parts were easily palpable per abdomen, and she was vitally somewhat unstable. On ultrasound, we found that the uterine cavity was empty. It was bulky uterus, but it was empty, and in the lower uterine segment we were able to see ruptured scar through which placenta was noted exiting, and fetus was totally expelled into the maternal abdomen, and it was noted, this is fetal abdomen noted near maternal bowel loops, and there was also hemoperitoneum, and this is the intraop image of the same. The findings were consistent with USG report, and the patient was luckily saved. And this is another case of second trimester uterine scar rupture. This time, a 31 years old woman with 4 months of amenorrhea came with complaints of reduced perception of fetal movements since 24 hours. There was no history of pervaginal bleeding, and this also was documented intrauterine pregnancy in previous ANC scan. She had previous history of 1 LSCS 3 years back. On examination, fetal parts were palpable in her maternal abdomen. She was luckily stable. On ultrasound, we were able to find empty uterine cavity with defect noted in the lower uterine segment. And this time, the previous one, in the previous case, the amniotic cavity was ruptured and there was gross hemoperitoneum. But this patient, the fetus was expelled with the amniotic membrane, intact amniotic membrane, with placenta noted in maternal cavity, maternal abdomen or peritoneal cavity. And in both the cases, there was fetal demise, and this time, there was minimal free fluid in pelvis. So conclusion, as ultrasound is a major tool in the diagnosis of obstetric emergencies like uterine rupture, availability of ultrasound in labor rooms and proper trained professional are vital for rapid diagnosis and management of uterine rupture, as it is life-saving, preventing maternal morbidity and mortality. These are my references. Thank you.
So good cases. So what is the moral of the story? How would you prevent this catastrophe?
So we can monitor scar
Very good.
size.
So what are the criteria?
So we can measure scar size and the adjacent myometrial thickness.
Very
If
good.
it is
So do you
less
do it in daily practice?
Yes, sir. We are doing it, sir.
Achha. So what is your experience till now? What are the scar sizes, and what methodology you use while you're doing the scan?
So thickness, the
So
adjacent
do you do it transvaginally, transabdominally?
transabdominal, sir.
Achha. So I'll tell you, because we've done a lot of work on this. Actually, some 5 years back, there was a thought that this is rubbish. Don't look at scars. But I have a different experience of 20 years. We measured scars in almost all patients of previous Caesarean. So transabdominally, they say that you do it with a partially full bladder, not a very, very full bladder. nowadays TVS, you will read, na? So lot of literature has come up on TVS way of measuring the scar thickness. So then you are measuring the scar. So when will you alert the obstetrician that this is not looking good?
So when the
Do you have
thickness-
any criteria? Measurement, I'm saying.
If it is less than 50%, we have to measure that adjacent myometrial thickness and the scar thickness.
Right.
If the ratio is less than 50%, then we have to alert.
No, but what is that measurement? You will say ki you need the gynec, you will forewarn the gynec. Millimeters. Cutoff of, do you know?
Less than 3 mm.
Very good. So it's a dictum now that moment you see a scar of 3 mm and you should also elicit tenderness along scar. If you get these two signs, you need to tell your fellow gynec, watch for dehiscence. I have some 10 cases, 3 mm, and then the scar dehiscence happens. So you should be categorically reporting in your reports that this is 3 mm, the scar is tender, monitor for scar dehiscence, because that will be life-saving for the mother and the fetus both. So very good, nice cases.
Thank you, sir.
Life saving for the doctors also nowadays. So